Testing. All right, everybody, quiet down. Hello, everybody. Thank you. Thank you a million times for coming. Thank you for. I'm going to do a quick review of this agenda, but I wanted to thank everybody for coming to Rochester Parkinson Network's Parkinson Disease Research Forum 2024. We're going to do this on every palindrome day going forward. And it's up to you to figure out when the next one is. I have no idea. And then you can talk to each other and figure out what palindrome day is. Okay, big shout out today to our, little louder? How's that? All right. Big shout out to the folks that have helped us make this possible today. The Rochester Parkinson Network Board and our generous donors, including MAPCO Parking, Rick and Sherry Goldstein. The coffee you're drinking is courtesy of them. So, you're going to want to thank them for that. All of our other donors, thank you so much for making this possible. I also want to give a big shout out to our volunteers from Nazareth University who have been helping people get in here today. And I want to name them individually. Rebecca Sachs, Emily Eddy, Ab Condon, Ellen Whalen, Zach Grant, and Elizabeth Halliday Kwan. And thank you so much. And also Jesse Preston, their fearless leader. I also want to make a shout out to my wife, Yvonne, because if she weren't here, I wouldn't, and I'm not sure if this would be happening without her. So, we're grateful to the Michael J. Fox Foundation for their support in making this event a reality, and to all the researchers that have agreed to share their insights and their important work with us. Thanks to all of you for coming. Thank you for being part of this network. You are the Rochester Parkinson Network, so give yourselves a big round of applause. It only works because of you. You all have a role to play in making people more aware that the organization exists, so that people in the greater Rochester area affected by PD have the information, the resources, and the allies they need to thrive. Between 4,000 and 5,000 people in Rochester have been diagnosed with Parkinson's disease. Add to that the number of undiagnosed, the mothers, fathers, sisters, brothers, aunts, uncles, spouses, care partners, friends, and colleagues, and we're talking about more than 20,000 people in the greater Rochester area that are affected by Parkinson's disease. There are 200 people here today. That's 1% of the people in Rochester that are affected by Parkinson's disease. RPN is relying on you to get the word out to people. If you know somebody with PD, somebody who's affected in one of those ways, let them know that you value the fact that this organization makes a positive difference in your life. Encourage them to take advantage of the services that we offer and that RPN makes available locally. And that's the big difference. It's local. So now for the big sales pitch. We're in need of volunteers. And we have a table in the back. And if you have a skill set and an urge and a desire to make this organization bigger and better and stronger, please see the folks in the back of the room. We are looking for all kinds of people. They're all listed back there. I'm not going to go through the list. You will have all the time you need after the formal portion of this program to visit the various researchers' tables in the back of the room. That'll be at about 3:30 or so. And we encourage you to wait until then because it kind of is a small space. And those people who are seated at the back tables may have some, auditory dissonance with the folks in the back of the room and the speakers here up front. Housekeeping items. The restrooms, I hope you've already found them if you needed them, but go out the door and there's a set there's a glass wall and a set of doors there. The men's and ladies' rooms are right there on your left-hand side as you go through those doors. There are guides from Nazareth all through the place here that will help you get around. If you need any help, just find somebody with a Nazareth name tag. Please watch your step as you're crossing this metal line here in the floor. There's a trip hazard there of sorts. We don't want anybody falling. Also, please pay attention to the waste containers. We have composting. We are composting virtually everything today. So pay attention to those signs above the waste bins. Quick review of the agenda. Check your agendas for the bios. On the back side, there are the bios of all of our presenters. Veronique Enos-Kafer and Abigail Woltman for the Michael J. Fox Foundation for Parkinson Research will give us a summary of the exciting work that the Fox Foundation is funding right now and the developments that are coming up on the horizon. Then Dr. Ruth Schneider from URMC will take a few minutes to tell us about the Fox Foundation Parkinson Progression Markers Initiative, or PPMI. That, let's see, 10 minutes for that, and then we'll take about a 20-minute break. So at that point, stretch, hydrate, use the restrooms. My personal yoga guru, my wife, says don't use your cell phones, they're bad for you. Next, there'll be a panel featuring 5 researchers from New York-based research institutions, the University of Rochester Medical Center, RIT, SUNY Binghamton, and the University of Buffalo. Each researcher will have about 10 minutes to describe their work and encourage you to participate in their studies. And there will be a little bit of time for questions within that 10-minute period. Following the panel, I'll make a few closing remarks, and then the Fox Foundation, RPN, and the researchers you heard from have tables at the back of the room. They'll give you further details about those studies and offer you an opportunity to sign up. Remember, you are the network. We need you. So I'm going to stop talking. I'm going to introduce our first speakers. They are Veronique Enos-Kafer, Abigail Woltman for the Michael J. Fox Foundation. Veronique is Vice President of Philanthropy at the Fox Foundation. She develops and implements strategies to engage the Parkinson's community in the Foundation's priority calls to action and help speed a cure for Parkinson's disease. She joined the Fox Foundation in March 2001, shortly after its inception. I heard that she was the 3rd person hired in the organization. She works closely with individuals living with Parkinson's disease and their loved ones and is deeply committed to the community and Fox Foundation's mission. Prior to joining the foundation, she worked in the field of mental health. She holds a BA in acting performance from Brigham Young University. Go Cougars. I had to look that up, though. Abigail Woltman joined the Fox Foundation in 2022 as an advancement officer. She frequently travels throughout the Northeast, meeting with members of the Parkinson community. She began her career in nonprofit events and holds a BA in history from the College of Worcester. And just so you don't feel left out, go Fighting Scots. All right, floor is yours. You evidently have to hold that.
Okay. Hi, everyone. Thank you so much for having us today. Here we can give it a sec while we wait for the deck to load. Oh, true. Okay. So again, thank you for the lovely introductions. But yes, we're with the Fox Foundation. And as mentioned, I started just about 2 years ago, and I am based in Boston, but actually cover all of the Northeast. So traveling all around to places such as Rochester, which is very exciting. And an interesting fact is about 4 months after I joined the foundation, my grandmother was diagnosed with Parkinson's. So it's been very serendipitous in a way to be able to be on this journey with her and also act as a caregiver while working at the foundation as well.
Hi, everybody. I'm so happy to be here. When we stand in rooms like this with all of you, it feels powerful, right? Like everybody here is doing something about this. And when I think about When I think about the leaders that have made transformative differences for Parkinson's disease, James Parkinson's, and all of the steps along the way, and then of course I think about, you're going to hear from so many researchers. There's so much work that's happening, and this is really a global effort that we're all a part of that has been transformative to this field. When I think about Michael, he was diagnosed with Parkinson's disease like so many of you were, and there's that juncture, there's that moment. And, I'm speaking on behalf of the people that I know who have Parkinson's, but I can only imagine there's so much that goes on in that transition when you learn of your diagnosis. And we all have decisions to make then of am I gonna start exercising? Am I gonna focus on spending more time with my kids? What am I gonna do now with this new reality? And I'm so grateful to Michael that he said, well, gotta do something, right? And I think each of us have had that moment where we decided we gotta do something. And it's a simple instinct, right? Do something. I think it's a natural one, particularly with something that affects life and our hearts and our families and the things that we love. And I think we often humbly feel like, who am I? But you only can't if you don't. And all of you are examples of doing. And I think the work of the Michael J. Fox Foundation and of researchers across the world are examples of doing. And it becomes something very real. We start small and then we just get the right people together who care, and then we put our minds together. And I have to say, and I'm excited to be here today to say, the field of Parkinson's disease research has absolutely transformed itself in the last 20 years and in the last 1 year. And we're going to talk about that. Abby and I are not researchers. We work within the Parkinson's community to, I guess, sort of bring the good news, and we listen closely when researchers talk. You will hear from other researchers today. But this year, I'm just teasing it, and we'll talk about it more later. This year, we finally have a definitive biological marker of Parkinson's disease in the body. Up until now, the markers that we had were symptoms, and symptoms are important in PD. When your doctor diagnoses you by watching you move, those movements are specific. So that's not nothing, but being able to measure biologically what's happening for someone means that we can start to fine-tune treatments. You know that phrase, if you met one person with Parkinson's, you met one person with Parkinson's. Could it be that actually there are biological differences, and therefore fine-tuning types of treatments that would be better for someone who is gait and balance dominant, for someone who is tremor dominant, or for someone who perhaps has something else that is also a progressive neurological disorder. This year, we have always worked extensively with all of the progressive diseases, and this last year that has become validated, that the processes involved in the majority of the progressive diseases are quite similar, and the work that we're all doing, the rising tides lifting all boats. So we're excited for that. I will give the mic back to Abby.
Thank you, V. So a little bit of background just on who we are as an organization. Of course, we were founded by the actor Michael J. Fox several years into his Parkinson's diagnosis. He was ready to come public with it, and as V mentioned, wanting to be able to make that difference. He partnered with our co-founder and now CEO, Debbie Brooks, and in 2000, they put together the Michael J. Fox Foundation. They were very strategic from the beginning, what we were going to fund, how we were going to fund it. One interesting fact I do like to share, from the beginning, they decided we will not have an endowment. Our goal is to shut our doors one day because we want to find that cure for Parkinson's disease. So any money that comes into the foundation is out the door, maximum 6 months in a researcher's hand, typically closer to 3 weeks to 3 months. And again, that's because Michael had a very strategic research vision on not only defining and measuring the disease, but of course finding that cure too. So making sure that whatever we are funding is looking to be the most promising at the moment to get us to either of those initiatives.
So what is it when scientists talk about what they're trying to do at the Fox Foundation? What is it? The Michael J. Fox Foundation exists to find better treatments and a cure for Parkinson's disease, and also to attempt to provide some of the best educational materials on our website and through webinars and through things like that. But what are our scientists' objectives? So we have the slide here, but I will also add that we want clearer disease definitions, better Parkinson's treatments. We want to foster better and more precise clinical trials and healthcare for all. Why do clear disease definitions matter? Well, it matters. I feel like we're kind of at a point that cancer was a few decades ago, where there was a time when I was young where you were diagnosed with cancer and there were a few routes that you would be treated, but it wasn't hyper-specific. And it's gotten more and more and more fine-tuned. And that came down to better disease definitions, knowing what kind of tumor it is, knowing how it folded. And someone phrased it well, like right now, because of this breakthrough and other reasons, we're at the end of the beginning. Now, that might sound not that optimistic, and I am incredibly optimistic. What I don't mean is that we don't have incredible treatments. Like, we've had 18 new treatments that have come to market soon, and we have hundreds of targets, like 176 unique targets in the brain, in clinical trials, trying to come up with treatments that are more than treating symptoms, that are getting to the heart of what Parkinson's disease is and treating it as such. The more we have better definitions and have a sense of staging of Parkinson's disease that is beyond how my symptoms are, but that's what's happening in my body, the better it's going to be in terms of getting to the right treatments. Better Parkinson's treatments means ones that don't wear off, don't have side effects, drugs to treat side effects, treatments for motor symptoms that are improved, but treatments for all of those non-motor symptoms that are sometimes are the most annoying part. Better Parkinson's trials. What do I mean by that? The right people in the right trials, better access to trials that represents the global community who has PD, faster trials, better recruitment, better knowing what's even available. And better Parkinson's policies, I would relate to healthcare for all, which is maybe there's a drug that's out there, but it never gets prescribed to a person. Maybe it's too expensive. Maybe someone is states away from a Parkinson's movement disorder specialist. Maybe someone has no resources at all. Maybe a Parkinson's care partner has quit their job to care for someone, and that is very impoverishing. So just everything it is about living with Parkinson's disease matters to us. We can move the slide. So there are different ways to think about how to wrap our head around it. I'm going to let Abby talk about the Parkinson's perspective.
Thank you. So yes, the Parkinson's perspective, again, so just to go back to Michael for a second, we of course were founded by a patient. We are a very patient-centric organization. We want to make sure that we are accurately getting an understanding of what it's like living with Parkinson's today. Of course, as we have mentioned, PD, and as everyone in this room knows, PD looks different on everyone. But we want to make sure that we understand PD's full progression from the very baseline. So the underlying biology of Parkinson's, what is happening in the body to cause that loss of dopamine, that clumping of alpha-synuclein, all the way through the entire disease progression.
The other thing I'll add about the Parkinson's perspective is there's no point doing research on something. I guess there might be a point, but we don't prioritize research that's not going to make patients' lives better. Like, if there's this drug and it doesn't help me button my shirt better, or it doesn't help me live my life better, and that we always want to be thinking about treatments along the journey of someone living with Parkinson's. Before diagnosis, can we jump in? Can we screen? Early within diagnosis, later as it's more established, what is the person living with Parkinson's experiencing? What are their unmet needs? How can I meet that? It's not enough to just replace dopamine now. as things change, I need to meet every single symptom that someone will come up with. We're not going to be satisfied till then. The pipeline perspective is about the machine that operates funding research and moving science forward. I'm going to talk about that a little bit more. And our guiding principles is what do we agree upon as a scientific community and as a patient community that are our priorities, our values, and what we're going to go after. So let's talk about the pipeline perspective a little bit in the next slide. So this little oversimple line up here is basically saying that there are as many steps in funding a treatment as letters of the alphabet, and it goes through lots of niche levels of expertise among scientists, and there are scientific handoffs that need to happen smoothly, efficiently, quickly to get all the way from what might be happening in an academic research institution to what's happening in end stages of clinical trials within industry, pharmaceutical companies, and then that gap in between. And when we came on the scene, what we found is that the funding sources tended to be different, and there wasn't a department of cures, and that there really needed to be business strategists accompanying these brilliant scientists to help with all the pesky steps of chaperoning the science along in the most possibly efficient way. Biology is hard. It takes the time it takes, but we want to get all the airtime out of it, all of the, everything that comes down to human error and our processes being slow, we wanted to get them out of there. So when we started the foundation, there was lots of room for improvement. There was also a big gap in which there was no funding because nobody's career got made of it. So we decided to tackle, what we did first was we convened scientists who were working on Parkinson's disease and everything related to it, and determined scientific priorities for the field. We determined them together. We also wanted to ensure that there was funding all along the way and everybody was talking to everybody. And what I have to say is that is ancient history, because now it is so robust, it is so healthy, the pipeline has never been more full, it is just chock full of nuts. As research comes to market, there is more waiting in the wings. There's so much happening behind the curtain that I just want to say to you, I'm excited about it because it's not just one thing within the Parkinson's field. It's many, it's hundreds and thousands of things, and it's working well. So that's good news. Next slide. Our guiding principles, we talked about this a little bit already. We want to define, we want to measure, we want to treat people really well with the right treatments for their symptoms. We want to enable access, get rid of barriers. If we create something, if we create a mouse that's born without alpha-synuclein, which we'll talk about later, which is a hallmark of Parkinson's disease, there's a clumping protein that's supposed to break back down. If we make a mouse, we don't want anybody to ever have to spend 2 years making a mouse. We just give it away for free. If we've got data, PPMI data, we're going to talk about that. That's a great biomarker study. Scientists download that information 2,500 times a day on average, and that's right. That's going to make it go faster and better. Next slide. Our guiding principles were people-centered. It's about people with Parkinson's. We want diversity. We want open, reproducible science. We want to share resources and be a great big community that all plays together well in the sandbox. Truly, among the research community, there's so much collaboration, so much love, so much sharing and excitement. We want external input to validate and guide our thinking, and we want partnerships that amplify impact. This is a very braggerly slide, which I will explain. So you cannot see this, but this is basically 1950s to 2000 when we started. That's the research that existed, that stack. Since we started, and it's implied, but I don't fully mean it this way, everybody, the field, it has exploded because these are the treatments, and each stack isn't 50 years, it's 5 years. So I feel good about that. But that doesn't mean we're done. We're beginning, but we're excited about the momentum and the pace that is really picking up.
And this all actually leads to our biggest breakthrough to date, our biomarker breakthrough. So exactly a year ago today, in April of 2023, we were able to publish the first biomarker for Parkinson's disease. For those of you who might be wondering what a biomarker is, I was confused about what they were before I started at the foundation as well. So a biomarker, what it boils down to is it's basically a disease indicator. So if you think of going to the doctor, getting your blood drawn, and your cholesterol levels being high, that's an indicator for like heart disease, something like that. So up until now, we did not have a test to detect Parkinson's disease. Of course, onset of symptoms, your doctor might diagnose from that or maybe order a DAT scan. But what's really exciting is we now are able to detect Parkinson's before the onset of any symptoms, before that dopamine is lost. So how we are doing this is we actually are able to take a synthetic form of the protein alpha-synuclein. It's a protein that everybody has in the human body. And for whatever reason, with Parkinson's disease, based on a variety of factors, that alpha-synuclein becomes toxic, it's sticky, it starts to clump. That causes the loss of dopamine, therefore the loss of the onset of symptoms. So we're actually able to take a synthetic form of that alpha-synuclein in a lab, combine it with a spinal fluid sample from the Parkinson's Progression Markers Initiative study, and we were able to shake it up at a much faster rate than it would naturally occur in the body. And when that was all done, if that protein had clumping, that was an indicator of Parkinson's disease. So this is very exciting because not only are we actually able to see that pathology for the first time, but we actually are already using this tool in clinical trials. And if we go to the next slide, that can discuss that a little bit more. So how are we using this in clinical trials? For the first time, we actually now have an indicator of who we need in these trials. So it's pushing the trials further along, making outcomes much more clear because now we know what to be looking for. And now we have a better understanding if treatments are working, which is really exciting. It's also helping us get to the point that we're able to fund research to just understand that underlying biology of Parkinson's disease. How is that happening? What is causing this initial clumping to occur? But also, it's setting the stage for us to eventually get to the point that Parkinson's could potentially be subtyped, as Vi mentioned earlier. Of course, with symptoms, everyone is looking a little bit differently, but maybe that will help us understand why and how we can treat these moving forward. And so with all of that, we are now very excited to say we are officially in the biological era of Parkinson's disease. What that means is we now finally have tools to be able to not only see the dopamine of someone who is living today with Parkinson's, so like a DAT scan, but we also have this alpha-synuclein seeding assay. So using those two in conjunction, we're able to view Parkinson's in those living with the disease today, which is really exciting because up until a year ago, we weren't really able to do that at all. So we now are actually able to objectively define Parkinson's now from the earliest biological stages of the disease. So instead of before defining it at the onset of symptoms, we're able to define it at the onset of that clumping. So potentially years before any symptoms even occur. And as I mentioned, we are mostly using this tool today in clinical trials, and it's already flowing very quickly and pushing that clinical pipeline forward very quickly. And with that too, because again, now we know what to look for, we're actually able to see and set our sights on prevention trial for the first time. So designing those trials, seeing what could potentially go in if you do have that clumping, and maybe slow that clumping over time, declump altogether. What can help us keep this alpha-synuclein from actually becoming toxic?
Okay, so when we say cure, so we all want a cure. So what do we mean when we say cure? I think ultimately we mean we find something that slows or stops the progression of the disease, that stops it in its tracks, that makes it go away. There are steps within that can feel perhaps not like a cure, but that can make things better. Of course, our treatments. Sometimes treatments can feel like a cure. But I think cure also has to do with where we are in living with our disease and what unique treatments we're experiencing. So let's talk about some of the ways, because there's not just one route. So we've talked today about the clumpy protein alpha-synuclein. It's definitely a very important target for Parkinson's disease. And so it's like a weird big word. Who here has heard about alpha-synuclein clumping before? Most of the room. That's good, because in this new era of biology that Abby talked about, there's going to be a lot of conversation with all of these diseases about toxic clumping proteins. Alzheimer's disease has a protein called beta amyloid. You may have heard about it as like plaques outside of the cells. Parkinson's disease, alpha-synuclein clumps inside the cell. There's a protein called tau that is often present when dementia is present. So this is a very important target, but it isn't the only target, and we're going to talk about a few. In early Parkinson's, we want to just slow or stop the progression in its tracks, just stop it right there, and that's going to make things feel better. When someone's been living with Parkinson's for 20 years, they may have lost more dopamine neuron function. Some of those cells aren't functioning as fast. We want to replace or restore what's missing. And then we would like to intervene before diagnosis. We now have, for the first time, this was also always like science hopeful, and now it's like science possible, that we're actively working on prevention and screening. And we're going to talk about that more, to identify or intervene. But let's dive into that first section. How can we slow or stop progression? What are the different routes we're taking to get there? Next slide. So there's almost too much on these slides, I recognize that, but an important area of study for the foundation is the genetics of Parkinson's. The genetics of Parkinson's, I'm not overstating it to say it has transformed our understanding of what is happening in Parkinson's and other diseases. That said, most of you have probably been told Parkinson's isn't genetic, and that's not wrong, but there are dozens of known changes that can happen within a gene that if you end up getting Parkinson's, it's because of that genetic change. Now, you might not ever get Parkinson's, and that risk might go up as you age. But there's so many of them, and they're all so different that me, non-scientist, early on, I'm like, what is going on? How can all of these genetic changes lead to the same disease that looks the same? And scientists are very interested in that question, and we're digging into what are those changes. What we're learning is that those genetic changes tend to have to do with our body's natural recycling systems. So I'll give you an example. GBA is one of the genetic mutations correlated with Parkinson's disease. If you have a mutation in GBA from both of your parents, you end up actually having Gaucher's disease, which is the collection of fats around your organs. It's really a very difficult disease. That doesn't sound like Parkinson's, but if you have a genetic change in GBA from one parent, that could lead to Parkinson's disease, which is the collection of an alpha-synuclein, tiny little protein within a cell. So in both cases, it's actually the collection of something that should be recycled and trash that needs to be taken out that doesn't get taken out right. So we're looking at our lysosome systems. So those are our systems that do that. That's like, your little compost and recycling pickup trucks that go all along the way. And at any point, if there's like a pothole here or a pile of sand here or there's a car crash here, it's not going to be able to travel as easily, which is why there can be so many potential genetic changes that each have a job of some kind. Like maybe one is like mitochondria. It brings energies to the cell that need to do the jobs. Maybe one of them is the one that actually breaks something down. It's like a little stomach that floats around and breaks things down, and it's not working right. So we are studying every single one of those, as well as inflammatory processes. so inflammation in our bodies is a good thing and a bad thing. It's very, very good if it's short-lived. I mean, not actually the inflammation, but the processes underneath. Like, you sprain your ankle, there's workers that come in, break down the broken stuff, and workers that come in and fix it, and so there's more there, and so it's swollen. If it lasts, there's toxic byproducts that make things worse. So we're studying how to break that down. I mean, all of you who exercise, which I feel like this is a big exercise town, that helps wildly with inflammation. It also, the other thing, this is a tangent, but the other thing that exercise helps is it produces growth factors, trophic factors, which exist in massive numbers when a baby's developing in the womb, but we also have them all the time, and they help our cells regenerate, regrow, function at their best. When you exercise, you put growth factors into your brain. You literally put medicine in your brain, which is a great thing. So, genetics. Should your children, your grandchildren be worried? No. Parkinson's is kind of sporadic. It's like a tornado. It hits this house and leaves all the rest on the street alone. But it's very personal, I think, genetics. I think for some people, like, knowing and having that information would just like be a cloud hanging over, and I think for some it's like energizing and proactive. So it's very personal, but some people do like to have genetic testing to know for altruistic reasons, to be in clinical trials, or just for the awareness that that brings. But we do study it because it's teaching us what Parkinson's is. Alpha-synuclein aggregation we've been talking about a lot. So you know that stair-steppy slide that showed all the like new drugs that have been coming out? Right around the time the foundation started. And I will say, I do feel like the foundation has been a powerful like connector, convener, like kind of a unifying center to touch all of the kind of spokes that work on Parkinson's disease. And right around the time we started, serendipitously, so before the foundation began, we didn't know about the genetics of Parkinson's, not very much. We didn't really know about alpha-synuclein. There were many, many things that we didn't know about that started right around then. Like this discovery, we knew about Lewy bodies, but this discovery that alpha-synuclein was probably really harmful came from discovering some families that had genetic mutations that caused more alpha-synuclein, and those families got Parkinson's disease. And so then it became a really strong target for potentially treatments and a cure. And then in the early stages, treatments to manage symptoms are usually very, very effective. And so we want the very best ones to give people in those early years with Parkinson's the best possible quality of life so they can do all of the things that they want to do. There is a misconception sometimes that I think is being educated across. So there's two kind of main ways that you treat the Parkinson's motor symptoms, and one is through like your levodopa therapies. And levodopa, I'm sure you know this, but I just think it's interesting. So if it could pass the blood-brain barrier, we would just give people dopamine. Like you give someone insulin if they have diabetes. But dopamine is a little too big to go through the blood-brain barrier. And I always thought about the blood-brain barrier as like it's like a turban wrapped around it, or like it's a force field. But actually it's, you've got your veins, you've got your big veins, and then when they get to the brain, they all get really, really small. There's like a lot of them, but they're tiny. And so if it's too big, it just won't go through. And that's good news. So levodopa isn't dopamine. It's the step right before dopamine. So that when your dopamine neuron looks at it, it goes, this is easy. This pie a la mode just needs its scoop of ice cream on top. Let me just give you that ice cream and get you out the door. And so it lets those cells, it just gives them a boost because they're like, you've done everything but the ice cream. And here you go. So it's actually interacting with your dopamine neurons. So in the early stages, you have more very healthy dopamine neurons. You have more cells to interact with. And so it can do that fast and quickly. Some people delay, I mean, I'm not a doctor. You work with your doctors about what's right. Some people feel like they can't take levodopa early because they've heard about dyskinesia. Down the road, maybe their body's not going to respond to it as well, and they may get extra movement. That has to do with where you are in your disease and what's happening with your dopamine neurons, because it's interacting with your dopamine neurons. So the day you would start to experience dyskinesia, if ever, will be the same day, whether you start levodopa now or wait 10 years. So anyway, if you have that question, you can work with your doctors about it. And then there's another kind of branch for replacing dopamine, which is dopamine agonists. These are synthetic versions of dopamine that are small enough that you can just give you the whole thing. It's synthetic, and they're kind of personal. Like, there's a little trial and error sometimes, and doctors will do like different combinations of what to take when. The other thing I will say, and we'll talk about this more later, is it's a good idea to work with a Parkinson's-specific neurologist who has extra certification as a movement disorder specialist, because they tend to stay very up to date with what is new and with treating each individual like as a scientist, because they may respond differently and there may be a combination of treatments that are going to work best for them. We have a bunch of clinician researchers in the room that you'll hear from later, which is great. Okay. I think I forgot. I had those slides. We talked about all that. What's the next slide? Oh, this is just saying, okay, so we'll talk about this for a minute. Wow. Okay. We just got a 5 minutes on. There are 13 trials right now whose job it is, they're in clinical trials, whose job it is to break down the clumps of alpha-synuclein in the body. Our belief is this is going to slow or stop the progression of the disease, certainly slow it down. This is our hope. There's lots of ways to get to that. One of them is immunotherapy, to kind of create a vaccine that would either give your body the antibody or teach your body to make the antibody that could break it down on its own. We're starting to get early results. There's a trial called the Pasadena trial that's starting to get early positive results, that this may be helping progression over time, which is exciting. And then there's a bunch of other ways to get at it, which is just like, break it up or help it slide out through. So you can just go to the next slide.
So what does a cure look like for middle to advanced PD? So really at this point, really from the onset of symptoms, so really starting at early signs of PD, any symptom, onset of any symptoms, 60% of dopamine is already lost at that point. So once you get to sort of middle to advanced PD, we're not only looking to, of course, continue replacing that dopamine that has already been lost, but also treatments for other unmet needs in PD, such as freezing of gait, off times, dyskinesia, and of course some other cognitive symptoms that come along with PD as well. So what we're really looking at this stage is things maybe, and again, this isn't all of them, but just a few to highlight: deep brain stimulation, that DBS procedure, and then we're also doing a lot of research into stem cells, and of course, as Veronique mentioned, those growth factors as well. We're actually looking more now at stem cells as a potential form of dopamine replacement, once we get a little bit further down the road in terms of this research, instead of a cure, which that was originally looked at a few years back. And I can go quickly through this slide, but this just shows some therapies that have been recently approved since 2014, so about the last 10 years or so. So these cover, of course, those off times that I mentioned. There's some on here now for Parkinson's disease psychosis, and then a few other ones for like blood pressure, DBS, things like that. And I know this is hard to see, so happy to share a little bit more in depth after this presentation back at our table. And then this is also, and again, apologies, I know it's probably hard to see for those of you in the back, but this covers just a few therapies that are close to possible regulatory approval, so are not quite yet on the market or through FDA approval yet. A few of them I do just want to highlight are the several variations of a subcutaneous pump. So what you might think of it as like similar to a pump for diabetes of insulin, but instead this is carbidopa-levodopa. So just trying to figure out different ways to provide carbidopa-levodopa and alleviate those off times as much as possible. A few other therapies we have on the horizon that I do just want to point out. So this right here is actually the Atom sensor, and this is not a medication, it's a medtech device, but as you can see, it's placed on the throat, and this helps with speech, swallowing, drooling, eating, of course, common symptoms of Parkinson's, and again, it's not a medication, so it's just placed on the throat and will send vibrations to the brain to help with those symptoms. And then another one I want to point out is Takeda is actually working on a medication that is combination gait imbalance and also cognition, which is really exciting because, of course, those are two very common Parkinson's symptoms. So if you're able to take one medication for two symptoms, that can potentially help cut down the amount of medications that might be taken throughout the day. And of course, our goal is to also make it that people can eventually get to the point that you tailor your PD medications as closely to your symptoms as possible.
Okay, we've been teasing prevention a lot. Let's talk about biomarkers a little bit. Why are biomarkers important? Why did we focus on them at all? About 10 years ago, we started to see so much research moving into clinical trials, but you manage the things you measure and you have drugs for the things you can measure. We can measure symptoms, so we have a lot of drugs that treat symptoms. We need measures of what's happening in your brain so that we can have treatments that are what's happening in your brain. So PPMI, we're gonna hear from Ruth Schneider next about the Parkinson's Progression Markers Initiative, which is basically measuring every single possible thing in your body now and in the future that could indicate Parkinson's disease. I got a 1-minute sign, so I'm gonna jump forward a little bit to something that a researcher said to me yesterday. So I apologize, you don't have a slide for it, and I have these notes that I'm gonna look at. But we want you to come away with a strong sense of strength in the field. Genetics has transformed our understanding of Parkinson's, but we know none of this work is done. We are still actively working. What do we need next? More data to support more ways of defining disease, a clear link between biology and clinical symptoms. We know there is a growing list of fantastic amounts of treatments that are addressing symptoms. What do we need more of? We need more confident and faster translation of disease-modifying biology. We need sustained investment in this. We know that the clinical pipeline is incredibly robust, has never been more robust, but we need better ways to measure progression, function. We need novel platforms and designs. We need more diverse representation among everyone who has PD. We know that healthcare awareness is improving, but we need clarity for newer therapies navigating to actually, from market to actually reach patients. We need improved access to quality of care for many who lack it. We need government policies that prioritize this. We also have a policy arm. We're working on the National Plan to End Parkinson's. It's a public-private sector initiative that works on every aspect of living with the disease. There are lots of ways to get involved with the Michael J. Fox Foundation or with your community. Respond to the way that moves you, that you feel inspired to. You can get involved in research. You can get involved in your community. You can get involved in fundraising, which is really community, and you can get involved in advocacy. We'll be at the table if you want to say, like, sign me up. How do I get involved? How do I find out about clinical trials? What kind of trials are available? You guys are awesome. I hope you feel the tremendous momentum that's happening. We're excited. We're on fire, and we hope that gives you some hope. Thank you. Questions? So the bioscreening, like how do you do it? So right now, hold tight, it's being used for trials. So it's getting the right people in trials. So if I'm working on a tremor treatment and I have people in my trial that are gait and balance dominant, it's not gonna it's gonna skew the data. So we're coming up with staging systems for what biological markers, including this one. But we are working super fast so that within the next 3 to 5 years, this will be a blood test that's available, that you can do it when you're doing your cholesterol, your annual with your doctor, and that it's easy. Because right now, this bioscreening, you can do it with the company directly, but it's a it's like a lumbar puncture. Just wait. You've already been diagnosed, but just know that it's being used right now in science. Dan. Why is it important that patients get involved in clinical trials? Because there will never be a treatment ever that hasn't gone through a clinical trial, that hasn't had a brave, altruistic patient sign up to be part of it. I don't want to ever overpromise clinical trials, but I feel like there are some side benefits of being in clinical trials in that you become an engaged and informed individual. You end up learning more about your care and in some ways like accessing care. Dan, you do 1 million clinical trials. How would you answer it? Why is it important? Okay. Yes. So we work really closely with the National Institutes of Health and the NIH, or that is the National Institutes of Health, and the FDA and all of these programs. When Michael started the foundation, he initially thought that he would just do advocacy. He went to Capitol Hill. He campaigned for there to be more funding. So the government funds about $200 million a year in brain diseases, but that's every single brain disease kind of all lumped together. So it depends how much is Parkinson's. He wanted more money to go to it. This is before he started the foundation. He got more money, but it wasn't spent. And so he decided, we just need to do it ourselves. We need to be irreverent. So we started this, we raised the money, we fund it. It doesn't mean the government doesn't fund it. We just have like a slightly different approach. And in many ways, both groups are becoming more and more aligned, and they've actually made a lot of the changes we have, and we love them, and they're fabulous. We're lucky in this country to have a National Institutes of Health, because in many countries, so like let's say a study costs $300,000, we and they, depending on who's funding the study, will fund the whole thing. But in many countries, you have to go to like 10 donors to get $30,000. And the country is committed to funding science. We just wanted to structure it differently. Like we wanted to do it thematically. Like let's do an initiative about breaking down alpha-synuclein clumps. Whereas when we came on board the National Institutes of Health, a lot of their studies would be like, send us your best idea. So they would fund fantastic researchers and great studies, but that's different from trying to answer a specific question and like put all your energy on like how, like the money is ahead of the science, what if, or like the science is ahead of the money, what if the money was ahead of the science? What if I answer everything there is to answer about GBA? So we just have different processes, but we work well together. I would say they are not trying to block things, but they have a lot of questions they're trying to solve, and we're pin-focused on Parkinson's. Yeah. I mean, that's a fantastic, smart question, which is like, just because I found out about this one gene, should I check up later because now you know about 12 more? I would say it's personal, like it's up to you. But if you already know, like there's LRRK2, it's unlikely that you're gonna have 2 genes that's influencing. And so you're probably good. When I would do it is when we have very specific drugs that treat that gene. So like LRRK2 is an example. It's just a gene associated with Parkinson's disease. We did some LRRK2 studies. Sergey Brin cares about LRRK2 because his mother has PD and she has a LRRK2 mutation. He's funded a lot. Like in 5 years, we got a tailored treatment for or we're in clinical trials, tailored treatment. And what we found is that LRRK2 activity in everybody, not just the LRRK2 population, anyone with PD is amplified, so those drugs would help everyone. I would say if there's a treatment, like you've already tested, you've already been in clinical trials for LRRK2. If there's a treatment that is specific to a disease and it's going to change your life if it applies to you, then test again. Take the last question or done? Last question? There's a lot of countries doing research. 60% of our funding goes to the United States, 40% goes outside of the United States. So I'd say there are comparable like researchers across the board. What's good is that we're all working together. Parkinson's is a super unified community. People share data, researchers talk and interact. So I would say we're all on the same team, but there's other countries that are great players too, which is just a boon. Thank you all so much. We'll be back if you have other questions.
Thank you so much for that eye-opening set of information. All right, our next speaker is Dr. Ruth Schneider from the Movement Disorders Clinic at URMC. Dr. Schneider is a board-certified neurologist with expertise in movement disorders who specializes in the care of individuals with Parkinson's disease. Her research focuses on the neuropsychiatric manifestations of Parkinson's disease, the development of digital measures of disease, and the development of participant-centered remote research designs. She's the site principal investigator at the University of Rochester for PPMI, which you just heard about, and Activate, a clinical trial examining a potential disease-slowing treatment. Dr. Ruth Schneider.
Hello, everyone. It's so wonderful to have so many people here today, so thank you all for coming out. I do not have any slides, so you're just going to listen to me chat for a few minutes, okay? So I'm here to talk to you about PPMI. PPMI is the Parkinson's Progression Markers Initiative, and the reason that I'm following Abby and Veronique is that this is a Michael J. Fox Foundation sponsored study. And it's really a landmark natural history study. What they're doing and what that means is that it's observational. So when you participate in this study, there's no drug or treatment that we're assessing. We're simply following folks over time and learning more about how Parkinson's disease progresses. So what's collected are clinical data, right? So having you do these tests that are all familiar to you, answering questionnaires. There's also a neuroimaging aspect, as well as collecting biological samples, so things like blood and urine and skin biopsies. And this study is really designed to identify new measures of disease. And they're really focused on neuroimaging measures and biological measures. And you heard a bit from the Michael J. Fox Foundation about why that's so important, right? So just to emphasize that, the reason we need these is because we can diagnose Parkinson's disease better. We can treat Parkinson's disease better by being able to tailor our therapeutic approach. And we can run better trials and find new treatments faster, okay? So PPMI launched back in 2010, and I think at that time they had about 30-some sites. The University of Rochester was privileged to be one of the original sites for PPMI. And thinking back to their original cohort, so they recruited about 1,400 individuals, and included in that pool of people were folks with Parkinson's disease, folks with Parkinson's disease related to a genetic variant, and then people at risk for Parkinson's disease due to either a genetic variant or something like poor sense of smell. As well as a smaller group of individuals who did not have Parkinson's disease to serve as what we often refer to as controls for research studies. And a few years ago, PPMI decided that they were going to, or MJFF decided they were going to reinvest in PPMI. So they already had this group of over 1,000 individuals, and they said, that's not enough, we're going to shoot for 4,000. And so they started enrolling a new group of participants in the study. And I joined the team here at the University of Rochester about 3-4 years ago, and have been really privileged to be a part of the PPMI team here at the University of Rochester. So now, the study as a whole is approaching 3,000 individuals across the US, and they've also broadened to include some global sites. So they have sites in Europe, and they have sites in Africa as well. So more than 50 sites at this point, nearly 3,000 individuals, including all the people who volunteered their time from those original studies. And their focus is still on recruiting folks with Parkinson's disease and at risk for Parkinson's disease. So I'll tell you a bit more about how to get involved at a local level. But first, I just wanted to highlight kind of two of my favorite aspects about PPMI. The first one is data sharing. So this doesn't sound like a big deal, but trust me, it is. But what they do is they make all of their de-identified data available to other researchers, right? So de-identified data means it's your data, it's just not linked to your name, your address, or any other personal information, right? So nobody can use it to identify you. And they make this easily accessible to other researchers. And the result of that is we don't just get publications from the PPMI team. We get publications from hundreds of individuals across the world. I mean, there have been several hundred publications that have come from the PPMI data. So it's really a way of growing their impact and broadening their reach. And that is a bit unique, right? So not every research team does that. Not every sponsor is willing to share their data. So I truly applaud them for that. And out of those several hundred publications, there's just too much for me to talk about as far as what they have found and kind of the scientific breakthroughs that they have contributed to. So I'll comment on just one that has gotten a fair amount of attention lately and that you heard a little bit about earlier. And that one would be the alpha-synuclein seed amplification assay. So alpha-synuclein, if you remember, is this phosphorylated misfolded protein that we see in clumps in folks with Parkinson's disease. And what this technology does is it's able to detect very, very small amounts, kind of amplify it to the point where it's able to be detected in the cerebral spinal fluid. And what that fluid is, we get that from a procedure in the lower back. It's the fluid that bathes your spinal cord and your brain. So that, and based on that test, they can distinguish between folks with Parkinson's disease and without. And they also can identify folks who are at higher risk of developing Parkinson's disease. So this stands to really help us to focus our participants for clinical trials to make sure that if we're investigating something that is looking at breaking down those clumps of protein, that we're only recruiting people who have them. And that seems straightforward, but up until now, we didn't have a way of doing that. So that's kind of PPMI and the impact that it's had. I should tell you about what we're doing locally and how you can get involved. So shout out to Anisha Singh, who's our coordinator in the back of the room there. She's hiding behind some folks, but you can find her at the end. And we have about 40 individuals who are participating locally at our site. So we're still looking for folks who have early Parkinson's disease, so recently diagnosed, not yet on any medications. We're also looking for individuals who don't have Parkinson's disease, but are interested in giving their time and sharing their data. And we're looking for people who are at risk for Parkinson's disease. And the at-risk groups that they are recruiting are people who know, for example, that they have one of those genetic variants that puts them at increased risk for Parkinson's disease. If you have a poor sense of smell, or if you have what we call REM sleep behavior disorder, or act out your dreams at night. So if you are in any of those categories and you're interested, come find us in the back of the room. There are 2 other ways to participate. So one is by taking a smell test. So you can find these flyers at the back as well. So Michael J. Fox Foundation is asking anybody who is 60 years or older and does not have Parkinson's disease to take this smell test. And it's a scratch and sniff test that they will send to you. And this is their way of identifying folks who don't have a good sense of smell and might be eligible for the study cohort. Lastly, anybody in this room can participate in PPMI online, and you can do this from the comfort of your home. So this is a nice way to get involved without having to sign up for any procedures or any travel to the clinic. And again, that's PPMI online. Already has more than 30,000 people contributing data there. So lots of ways to get involved with PPMI. I'm getting my 1 minute sign, so I'm gonna stop there. Thank you all for your attention.
Thank you, Ruth. Watch that step. All right, we're going to take about a 15-minute break here and be back at 2:30. So hydrate, stretch, and use the restrooms and talk to each other and get to know somebody you've never met before. For those of you that have been interested in volunteering for the Rochester Parkinson Network and have taken a volunteer sheet, if you wouldn't mind filling it out here and dropping it back off at our table at the back of the room before you leave today. We would really appreciate that. Next is our panel of experts. They're here to discuss the research each is working on and their respective universities. Our panel consists of Dr. Jamie Adams from URMC, Dr. Tom Gattuso from the University at Buffalo, Dr. Robert Osgood from RIT, Dr. Gurpreet Singh, along with Wellness 360 co-owner Lindsay Perez, who is walking around somewhere or sitting somewhere right there in the back of the room. So get to know her, by the way. If you don't already, you need to get to know Lindsay. And Dr. Ruth Schneider, also from URMC. Think of this as our lightning round. Every panelist is going to have 10 minutes, right? And they'll have about 8 minutes to talk. You'll have 2 minutes to ask questions. They'll repeat your questions up here. Don't worry about waiting for a microphone to come to you. But this is also like speech therapy, right? So you guys way back in the back of the room there, when you have a question, you got to yell it out, all right? Me, my, mo, moo, whatever. Okay, hopefully after this section of the program, you'll have plenty of time to go back, if you haven't already, and take a look and stop by the research tables and offer up your body and your mind to be a subject for their research. And with that, take it away, Dr. Jamie Adams.
Hi, everybody. I'm Jamie Adams. I'm delighted to be here. I am a movement disorders neurologist at the University of Rochester. Seen a lot of familiar faces. My research focuses on the evaluation of digital measures and digital technologies like smartphones and wearable sensors as more objective and sensitive measures of disease. Currently, Parkinson's therapies are approved based on subjective and episodic scales. So research participants come into clinic, and we have them do a variety of tasks and fill out a set of questionnaires. And these scales may not be an accurate representation of how an individual truly functions or feels. More objective digital measures may be a better reflection of everyday life. So instead of having you come in and tap your fingers and us giving you a score of 0 to 4, we'll monitor people with a wearable watch or a smartphone application that might ask you to tap your fingers or do a variety of tasks. I've also led or been involved with a number of studies that are remote, where research visits are performed with participants in their home with the aims to allow for more broad research participation. For this event, I was asked to discuss the LIGHT PD study, which is kind of a combination of these interests of mine. This is a phase 3 double-blind randomized controlled trial sponsored by Photopharmix and being conducted by the Center for Health and Technology's Clinical Trial Coordination Center at the University of Rochester. Ray Dorsey is the principal investigator on the study. I'm the co-PI and also conducting visits, so if you enroll, I may be someone that's doing some of your assessments. The study aims to recruit 300 participants from across the country. It's fully remote, with all visits performed over video in participants' homes. Participants have 4 remote visits over about 6 to 7 months. There's a screening visit, and this is followed by a baseline visit and then visits at months 3 and 6. The study is evaluating the Celeste specialized light therapy device, which there is one of in the back corner table where our coordinators are sitting, if you'd like to take a look at the device, versus a placebo device, which emits the same color light but not at the therapeutic intensity. So no way to tell if you're receiving the light that's emitting the frequency of light that's therapeutic versus the placebo device. It's bigger than a tablet, but it's slightly bigger than a tablet-sized device, which you'll sit next to for about an hour every evening. And you don't have to be staring. They don't want you to stare right into it. It just needs to be about arm's length, and your face has to be exposed with your eyes open. So phototherapy, which is what we're evaluating here, is thought to improve circadian rhythms and may, by doing so, help improve motor and non-motor symptoms, things like fatigue, depression, and other things in people with PD. And early studies were promising in this regard, and the therapy was found to be safe. So that's why we're assessing it in this phase 3 trial. Mechanisms of action in light therapy for Parkinson's are not known. The leading hypothesis is that the specialized light may be supplementing a damaged ocular pathway and improving function in people with PD through improved circadian rhythm function. For the study, you have to be at least 45 years old, have a diagnosis of Parkinson's disease, have responsiveness to Parkinson's medications, and have been using treatment for at least 1 year, have relatively good eyesight, be taking a stable levodopa or other Parkinson medication drug for at least 28 days prior to screening. So if you or your doctor think that you're going to need changes in the near future, best to wait to go through those changes before enrolling in the study. You cannot have a deep brain stimulation device to participate, cannot have dementia, significant eye disease. What this means is things like glaucoma, macular degeneration, no prior use of light therapy, and cannot be participating in another interventional study. We have our coordinators here. As I mentioned, they're in the back left corner if you're going back there, and they can answer any questions that I'm not able to answer, but that's all I had, so happy to take questions if there are any. That's a great question. I think some of that is, there probably is a scientific reason that I'm not aware of, but I think some of it is just make sure people are getting it at the same time every day. Oh, sorry, why are we having people use it at night? Yeah, so this study is not looking at seeing if it improves REM sleep behavior disorder. I think some of the mechanism for that might be slightly different than what we're looking at here, but good question. Dan. How long is the study? Yep, so it's a 6-month study. There is a screening visit prior to enrollment, so probably about 7 months total. And again, we're looking to recruit 300 people across the United States, so we need a lot of folks. So if you're interested, would really be happy to have you participate. So the question was, can someone be involved in more than one clinical study? Some of this depends on the study. So many interventional studies do not want you participating in other interventional studies. What an interventional study is a study that's looking at a drug or a device. And so for this reason, for this study, they do not want folks that are in other drug studies. There are sometimes studies that will allow people to participate in observational studies like PPMI, and others, and also participate in an interventional study. Yeah. Yep, so the primary outcome measure is a scale. Oops, sorry. What are the outcome measures being looked at for the study? Are they fatigue or depression? So the primary outcome measure for the study is a scale called the PDQ-39. It's actually an activities of daily living scale, and some of that was based on what they found in earlier studies. But also secondary measures are looking at a scale of fatigue, a scale of depression, and our MDS UPDRS parts 1 and 2, which is a motor, non-motor patient surveys. Sure, one more question. Yeah, no, this is a good question for a lot of interventional studies, right? Like what happens at the end of the study? I don't have the answer to that yet, but can try to find that information out. There are other light therapy devices, so it may be something that if this device isn't readily available right as you end the study, you might be able to get another device. They are hoping if it is shown to be beneficial to have FDA approval, and then the light therapy would be available to anybody. So, okay.
I guess I'm next. Was that for me or for Gene? I'm Tom Gattuso. I'm also a movement disorder neurologist, but I'm an hour down the road at University of Buffalo. Thanks to Yvonne for the invitation. Thanks to all of you for showing up. It's great to see you all here. It's a great turnout for this event, which I hear is the very first event like this, so it's a fantastic start. So I want to talk to you a little bit about lithium. We are conducting a clinical trial looking to see if low doses of lithium can potentially improve certain biomarkers and eventually see if it can slow the progression of the disease. So a disease-modifying therapy. When you think of lithium, maybe the first thing you think of is the battery in your cell phone or your computer or your car if you have an EV. Yes, that's lithium. You may also think of lithium as a medication, a prescription medication that's used for treating a psychiatric condition called bipolar disorder. That's also lithium. One interesting thing about lithium is, which I'm just finding out today after the Michael J. Fox Foundation presentation, that Michael J. Fox started the foundation in 2000. And that is right around the time that many researchers from across the world were starting to discover that lithium had a multitude of neuroprotective actions, and even in very low doses had neuroprotective actions. So what does that mean? Neuroprotective means that is protecting brain cells from dying, from a variety of different insults. It could be from stroke, from brain trauma, from a variety of different toxins, and eventually in animal models of both Parkinson's disease and Alzheimer's disease, which is much more common than Parkinson's, but Parkinson's and Alzheimer's kind of share some similar physiology, if you will. The destructive processes, the things that are going on in brain cells in both Alzheimer's patients and Parkinson's patients, of why these cells progressively die over time and symptoms get worse, they're very, very similar. And initially, lithium has been studied in clinical trials in patients with Alzheimer's disease, maybe because it's so much more common than Parkinson's. And using low doses of lithium, there's been 2 clinical trials, both conducted in Brazil, that have shown low-dose lithium to actually slow cognitive decline in patients with Alzheimer's. And one of these studies showed a positive effect on a biomarker for Alzheimer's, implying that it's actually protecting brain cells and affecting the underlying cause of Alzheimer's disease. So it's kind of exciting for the field of Alzheimer's. There's actually a big study going on right now at the University of Pittsburgh. It's kind of the best study with low-dose lithium in early Alzheimer's patients. Those results are going to be published this fall. So you may be hearing about some exciting news with lithium for Alzheimer's. What about Parkinson's? That's what our group at University of Buffalo has been focusing on, is using low-dose lithium for potentially slowing disease progression in Parkinson's. And the way that we're analyzing this, the way we're assessing it, is by focusing on 2 particular biomarkers, disease progression biomarkers. So different than what you heard before about the alpha-synuclein amplification assay, which is a spinal fluid test. You have to get a lumbar puncture. The particular biomarkers we are interested in are really the 2 leading disease progression biomarkers that are known. So these are measures of ongoing damage that's occurring in brain cells. One of them is assessed by an MRI scan, a conventional MRI like many of you have probably already had. And the particular assessment is called free water. Free water is increased in patients with Parkinson's in particular brain sites, especially the dopamine part of the brain. And it progressively increases over time and charts progressively worsening symptoms. There's another blood test called neurofilament light. And so this is just a standard venous blood draw from the arm, and we can send it to a special laboratory to measure this particular protein. It's also go by the name NFL, not to be confused with the football league. So both NFL and free water measured by MRI scan, these were discovered as disease progression biomarkers from this fantastic PPMI cohort that Michael J. Fox Foundation has funded. And in my opinion, I think it's the crown jewel of what Michael J. Fox Foundation has provided to the Parkinson's community. It's pretty amazing, this trove of data that any researcher can access for free and research their particular question. So it's hats off to Michael J. Fox Foundation for funding this trial that is still going on, and Rochester is a site looking for more participants. So for people who are interested in our lithium study, what's involved is a trip to Buffalo at the beginning of the study. It'll be 2 trips to Buffalo, and then 1 trip at the end of the study. People are going to be randomly assigned to either low-dose lithium or to a placebo, an inactive treatment, in a double-blind fashion. There'll be an MRI scan and a blood test at the beginning of the study, and then after 6 months of treatment, there'll be an MRI scan and a blood test at the end of the study. So the reason that we're doing this study, which is funded from 2 different groups, the larger funding group is a group in England called the Cure Parkinson's Trust, is we did do a pilot study about 4 years ago. And what we found in this pilot study, in a very small number of patients with Parkinson's, is that people who were on lithium, instead of their free water increasing over time, we actually found in this small number of patients a decrease in free water in both the dopamine part of the brain and a few other important parts of the brain for Parkinson's patients. So that's a definite positive signal, and is actually the first time any therapy has been shown to decrease free water within the brain. So we were excited about that, but it is preliminary because it is from such a small number of patients. Thanks. So in this study, we're hoping to replicate what we found in our pilot study in a larger number of patients. And then we're also looking at free water. We did get a positive signal with, neurofilament light with NFL. We got a positive signal with NFL as well. So we're pretty excited about this study. And I will take any questions that you might have. Yes? Yeah, so the question is there any cost involved with the study? There's no cost. All of these are covered by the study, by the funding that we received, and most clinical trials are like that. Yes. Yeah, people who are eligible for our study, which I think is what you're getting at. Oh, no, that was for Jamie's study. Well, it wasn't 60, it was 45, right? Yeah, it was 45, yeah. For our study, let me think, you have to be between the ages of 40 to 80, and you have to have Parkinson's disease diagnosed within the past 4 years to be eligible for our study. There's some other criteria too, but those are the kind of main ones. Yes. Yes. Yes, the question is lithium added to, if you're on Parkinson's medications, to what you are currently taking? The answer is yes, and you can be on Parkinson's medications for our study as long as you're on a stable Parkinson's regimen for the past 30 days, and it's added to it. And we're, like I mentioned, we're studying low-dose lithium, so that's a big difference from the higher doses that are used for treating bipolar disorder. We're using doses between 20 to 45 milligrams a day. Typical dose for bipolar patients is about 300 milligrams a day. Yes? Good question. So the question is, are there any side effects from lithium in the dosages that we're studying that could maybe tip off a patient to say, hey, I'm on the real stuff, I'm not on a placebo? So this study is open for enrollment right now. We've enrolled, time is up. Right now we're not seeing patients reporting side effects from the therapy. So that is it. Thank you.
Hello, everyone. I'm excited to represent RIT along with my team in the back. We have a couple of students in the back that are helping with this. And as you have read, what we are intending to do from a research standpoint is to, oh, you can't hear me? Okay, sorry. So what we're intending to do with our research study, is that better? Okay, so what we're intending to do, for the third time, what we're intending to do with our study is to use Tai Chi, which is an ancient form of martial arts that has long been known to be beneficial in helping with movement and strength, building strength. And so our intention is to have a group of representatives that have Parkinson's disease that will go through a 9 to 10 month intervention with this Tai Chi. We have trained students that teach them Tai Chi over the course of that time length. And for controls, we'll have, participants who will also be a part of the study, but they won't go through the actual Tai Chi intervention, either because they cannot or they decide not to. So we can sort of kind of use that population as a control. So some of the metrics that we would like to measure with this intervention is, things like, sitting to standing position time that it takes you to move from the sitting position to standing. We measure grip strength, blood pressure, being able to move the hips, abduction, adduction, all of the types of movements that come into play every day for Parkinson's disease patients that tend to be difficult. And most people that don't have Parkinson's disease, it wouldn't be so difficult. One of the things about Tai Chi that is very interesting and hopeful to me and some of you who know about Tai Chi, I was sitting at the table kind of minding my own business and purposely overhearing some conversations from people who were talking about Tai Chi. And to be honest with you, I've never heard anyone say anything bad about it. From our dean who brought this to our campus, Dean Wang, who couldn't be here today, one of the things that he mentioned was that Tai Chi, in the beginning, you learn it, and then you get to where you just don't want to leave it. And that's one of the things that we're hoping will still be true with our study, that after this study is over with, there will be a demand. We want more. We want more Tai Chi, and that's a great thing because it means that the benefits of Tai Chi will outlive what we did with the people that participate in this. Now, as an add-on to teaching Tai Chi to the group, we will also monitor a molecule that you've heard a lot about already. By training, I'm not a neurologist of any type. I'm just interested. It just seems like a problem that needs to be solved, and I feel good about what I've seen about the prospects of being successful and getting something that can not only leave hope, but can improve your quality of life. But the thing about Tai Chi that I love about it is that it sort of has a potential to attract the attention of a much younger population. By show of hands, how many people have grandkids or kids who may be interested in learning Tai Chi? Can you imagine having them put you on the spot and say, whatever you're doing, stop it, it's time for Tai Chi? And then you have to kind of go in because these are the grandkids. Of course you're going to say yes. And then you go in and then you continue this. And this is one of the things that we're excited about. So we're going to study the levels of alpha-synuclein right from the beginning of all of the participants, and then we will study that at the end. We will also be continuously monitoring the metrics that I mentioned before, particularly the ones at the end of the study, to kind of see where they are. How different are they from the beginning to the end of the participation period, and see is there anything significantly that we can see that improved from the use of Tai Chi. It seems that we have history of Tai Chi on our side, that we expect to see some great results out of that, but we'll wait and see what our own study tells us about that. So I'm excited about the study. I'm excited to be a part of it, and this is an exciting time for Parkinson's disease research, I believe. From all the stuff that you've heard and seen before, you should have some excitement as well. I'm new to Parkinson's disease. As I said earlier, I'm a microbiologist. And secondly, what I'd like to do is a follow-up, and this is into the future. And I don't want to say I as me by myself. Of course, the team of students that will be with me is explore the gut microbiome, the community of organisms that live in the gut. There are emerging results that are coming out saying that connections are being made between some of the very bacteria that live in our guts actually communicating with the brain, and they're sort of having an effect on Parkinson's disease. So as a microbiologist, that's a lot more interesting to me, and so I could see turning my attention to that in the future. So with that, as an introduction of the use of Tai Chi as a way to improve the quality of life in Parkinson's disease patients, I'd like to take some questions if you have any. Yes? Have we looked at Qigong? That is the question. No, we have not looked at that, but we're still open to, taking a look at other interventions other than Tai Chi. But chat with me, if you don't mind, me and the students at the RIT table in the back, and let's get that down on paper, and then we can look into it. Yeah. Other questions? Yes, sir. Okay, I heard about half of it. There was a sneeze that got in the way, and so I didn't hear the second half of the question. Could you repeat? Yeah, it's in our study, we'd like to see 2 times a week, 3 if it can happen, but 2 is very reasonable. 3 is the best. You know how you go and buy stuff, good, better, best? We'd like to see 3 if we could get it, but we think 2 is very reasonable and doable. Yes, ma'am. Yeah, it's going to be somewhere 9 to 10 weeks of intervention with the Tai Chi. Yeah, that's long enough to hopefully see some differences. That's what we're hoping for. Yes, ma'am. Okay. Yes. Yeah, we've been training the students that are going to be teaching Tai Chi to the participants of the study for much of the semester. And to give you that in terms of weeks, I would say for a good 7 to 8 weeks now. That's a safe approximation of how much training they've been getting. They've also been getting training in how to use the instruments to properly make the measurements so that there's not a lot of variation between if I take a measurement and then if another student takes a measurement, and they're just completely widely different from each other, that's not helpful. So they've been trained on how to properly take the measurements as well. Yes, sir. Okay, yeah, so the question was, what is the length of time that the Tai Chi practice will be taught? And we're looking at 9 to 10 weeks. We tried to time it to where, oh, okay, so there, I see what you mean. There is a morning session, you know, that will be happening. It's going to be done at the Awandakoi Library. And so we figure that's a nice spot to be at. But there'll be a session in the morning, and then there will be one in the afternoon as well. Yeah, it's not going to really take an hour. I would say it's probably going to be somewhere from 30 minutes to 45 tops. Yeah, so they're not really long sessions. And as with any exercise, you know, there will be, I guess if you want to call it a side effect, there may be a little soreness in the beginning, but as you begin to move, that will go away. That's the whole point, to sort of get you moving. The kids were right about moving the whole time since they came. When they were first born, they started moving. They run around for many years, and then very gradually they slow for different reasons. But with the Tai Chi is to get this particular population of people back moving again. And we'll see how that turns out. I'm hopeful, but I got to wait for the data. Yes, sir. No, right now we don't have any plans for it to be virtual. We're still signing up participants. If that forces a need for, you know, to offer some virtual courses or times for this, we could reconsider that. I'll add to that right now another thing that I think you should know about. For those participants who may be a little bit leery of the movements, you know, we could also bring in a chair form of Tai Chi in case your balance or your gait is a problem, and you know, that sort of sets up a fall risk. We can also have a chair form of intervention that participants can use. It's all about the safety. I'm getting a sign that's pretty clear. It says time is up. So I think you'll have to see me in the back. Officially, I'm out of time, and I want to respect that. But see me and my students in the back, and we can answer any other questions that you may have. Thank you so much for listening.
All right. Hello again, everyone. So just as a reminder, my name is Ruth Schneider, and I'm from the University of Rochester. So you already heard all about PPMI. So this time around, I'm going to tell you about another study. It's called Activate, and this is sponsored by Be All Pharmaceutical Company. And what this is a clinical trial that is looking at the ability for a treatment that is targeted for individuals with a specific genetic form of Parkinson's disease. And they think that this treatment may slow the progression of the disease, okay? So you've heard a lot about Parkinson's disease today. We haven't talked too much about the genetics, so I'll just say briefly that we think about 10% of individuals with Parkinson's disease have a genetic form. And there have been several different genes that have been associated with Parkinson's disease. This study is specifically looking at GBA1, or glucocerebrosidase. And this is actually one of the most common genetic risk factors for Parkinson's disease. And when you have this variant associated with Parkinson's disease, we know that an enzyme activity of this enzyme is compromised. So the drug in this study is targeting that enzyme, okay? So what this study is, another double-blind, placebo-controlled, randomized clinical trial. And so again, what that means is folks would be assigned randomly to either one dose of drug, a second dose of drug, or to placebo, which is an inert inactive substance. The duration for the clinical trial is about 1.5 years. So it is a bit more of a commitment than some of the other studies that you've heard about so far. And all of the activities are done in person at our site at the University of Rochester. The good news is it's a pill, so it's something that you take by mouth. Secondly, there's no imaging unless you optionally decide you want to do that, so you don't have to get in the scanner. And there's no cerebral spinal fluid collection, so no lumbar punctures in this study. We do take blood for it, though, I should mention. So about a 1.5 year commitment for it. And specifically what we're looking for is folks who have Parkinson's disease, who've been diagnosed sometime between 1 and 7 years ago, and are on a stable treatment medication regimen, okay? It unfortunately is not open to folks who have had deep brain stimulation or DBS surgery. So how do you know if you have the variant? Most people don't know, and there is no way that I can tell just by examining you or talking to you whether you have the genetic variant. So the first part of the study is actually screening. So if you don't know your genetic status, that's okay. If you're interested in the study, we're happy to bring you in for screening and let you know whether you have the genetic variant or not. It's only those individuals who have this specific GBA variant, one of a few, who would move forward to the actual clinical trial portion of the study. Now, there are some things that tell us maybe someone is at a higher risk of having the GBA variant. So people who have a family history of Parkinson's disease, people whose Parkinson's disease symptoms maybe started a little bit earlier in life, and then those who have a Ashkenazi Jewish background. But again, we are welcoming anybody who wants to screen for the study. You can see our coordinator, Hannah Mesmer, who's at the back table there. She's waving. So I think that's all I have about that study. I will mention just briefly, if there's anybody in this room who participated years ago in SURE PD3 or STEADY PD3, come find me after and I'll tell you about another study opportunity. With that, happy to take any questions about the BE-ALL study. Yes. I'm sorry to hear that. That sounds incredibly frustrating. You can come find me after. I'm happy to talk to you and try to help you navigate the system a bit. We have a great memory care program at the University of Rochester, and they take excellent care of folks who have dementia. So happy to help connect you. Yes. I think the question was about a stable medication regimen. Is that right? So for this study so we can screen folks who are not on a stable medication regimen, but before we start participation in the actual treatment part of the clinical trial, you have to be on stable medication for 30 days, I believe. Yes. Great question. Yes, the screening is a blood test. The screening visit takes less than an hour. During that time, we go through the consent form with you, make sure you understand kind of what you're signing up for and what you're being asked to do. We talk a bit more about the genetics of Parkinson's disease and what type of results you get back as part of this study. And then you go through a brief neurological examination just to confirm using kind of more stringent research criteria that this is indeed Parkinson's disease. And then there's a blood draw that we send off to determine genetic status. And then after that, we'll meet with folks again to give them their results and kind of talk them through with them. All right, well, if there's no more questions, I will hand off to the next speaker.
All right, hello. Can you all hear me? I'm good? No? Have to speak a little loud. All right, I'm Gurpreet Singh, and I'm from Binghamton University. I'm glad to be here and very excited to talk about our study that I've been doing here with Lindsay. So I'm a physical therapist by training, and I have a PhD in rehab sciences. So my PhD work was on gait and balance in Parkinson's disease. So I've worked with Parkinson's for over 14, 15 years now. And one thing that I realized is any form of exercise you do, whether it's yoga, tai chi, simple exercises, stretching, strengthening, walking, they're all going to make a difference. So anything that helps you, please participate in that and keep doing that. The one study that we are doing right now is rock study boxing, and I believe it's a great exercise. If you think about movement issues, we're not able to take quick movements, we're not able to do quick movements, sit to stand or walking, there's freezing. So what boxing does is it works on smaller, quick movements. So that's one of the big things that rock steady boxing does. And also there's more, agility type of exercise where you're actually working on your endurance, you're improving your ability to do exercise. So it's really a great form of exercise, and there's great results out there. It's already existing. It's been running everywhere. We're doing it. All the results are out there. What we're looking now is COVID made us move indoors, and we were not doing enough exercise, walking or anything. So that's when I realized, or my team realized, that we need to come up with something which is equivalent to what we can do in the clinic. So this particular study is rock steady boxing for 6 weeks. And we have 2 groups. One is in person, where Lindsay at Wellness Clinic here in University Avenue is doing that. And then the second group is online group, which is completely online, and they are actually following what Lindsay's doing in person in the clinic. It's 6 weeks, 3 times a week for 1 hour every time. Our inclusion, those who have diagnosis of Parkinson's and then above the age of 40 years can participate in this. If you've done rock steady boxing prior to this, if it's more than a year ago, you can still be eligible. If you've done this recently, please come see us. We can get your information. We'll let you know as soon as you're eligible. What else? I was told not to create a PowerPoint, so I am running out of words here. Like what else I need to talk about the study? Is there anything? All right, assessments. Yeah, thank you. So it takes about, we do 2 assessments in the beginning and in the end. Most of the assessments are gait motor symptoms and non-motor. So we have gait, balance, we have sit to stand that we look at. We also have a cell phone app which we developed at Binghamton. We'll look at the gait or walking data, so we get to know what speed of walking that you started with, and at the end of 6 weeks, what do we have? There's PDQ 39 that we look at, that's quality of life, Parkinson's. We look at fatigue scale, which is again a non-motor. We look at that following 6 weeks of rock steady boxing. And then a couple other things about the studies. If you decide or if you want to participate, we have a table in the back for Binghamton University. Those who do not have a device, they can use online, like for the online version of it. We provide that for the period of 6 weeks, thanks to Binghamton Research Foundation and American Physical Therapy Association. They funded the study. And one last thing is that we also use a Fitbit device, which goes on your wrist as a watch, and we track how much or what activities you did in addition to the exercise that we are doing in the clinic. So we really want to know if more activity is producing better outcomes. So we want to look at the real effects of rock steady boxing and also want to know if more activity is helping. Yes. I think we are trying to match what we're doing in person and online. But one of the ways we're going to be looking at the differences is, again, the Fitbit device is for all the patients, all the participants, and we look at their heart rate and their RPM, and we get that information. So we're trying to match that. I think that's all the information I have. Lindsay, you have any additional? Right, so that matches the intensity. We look at the rating of perceived exertion following the exercise for both the groups. So that gives us an idea if we are matching both the groups. So again, one of the bigger ideas at Binghamton is to do something for the rural communities or individuals who cannot come to you. Again, Parkinson's being progressive, we want to do something people can, keep doing at home as well. And as I said earlier, the more you do for exercise, the better outcomes you're gonna have. So that's the intention. With that, I end. Any questions? Yes. Oh, thank you. That's a great question. There is a class, so there's multiple people in that class, and not individual, but you still get individual attention because your program is created based on what your assessments are in the beginning. Yes. Oh, great question. So everything is paid by the study itself, so you don't have to pay anything. Even the device, if you need a laptop or an iPad for exercises, and the Fitbit device. The only thing we require is that it comes back to us so we can retrieve the data. Any other questions? Yes. So we're using actually the boxing gloves, and there is, so it's shadow boxing, so it's not actually competitive, or you're not actually competing with another person. It's shadow boxing. So great questions. Any other questions? Yes. Mm-hmm. I can give my opinion. That's great. As I said in the beginning, any exercise, as much as, so American College of Sports Medicine and APTA, which is Physical Therapy Association, and Parkinson's Foundation, they all recommend that you do continuous activity. It shouldn't be like just one day a week. One other thing which I can add is, based on my experience, I've probably seen thousands of Parkinson's patients. I was at a movement disorder center. That's where I got my PhD in Kansas. So what I noticed is, the more variety you add to your exercise, the better you're going to be. Because it gets monotonous. You get bored with an exercise or a type of exercise. And the recent research has shown us that it is neuroprotective. So the earlier you start, the more you do, the better outcomes you have. So any form, anywhere is always good, as long as it's safe and being, taken care of by someone who knows it. And that's great. That's wonderful. I love the idea of having it in a YMCA so people can actually, it's more visible. It's great. All right. I think our time is up, and I'm going to pass the mic. Thank you.
Thank you all. Thank you all for wonderful presentations. Thank all of you for coming. Please take some time and check out all of the tables in the back. Please sign up for research. It is for your benefit. If you have signed up to, or if you have taken a paper to do some volunteer work for Rochester Parkinson Network, if that's something you're interested in, please fill out those sheets here and drop them off at the table at the back. Once again, thanks to everyone, and thanks as well to the folks from Nazareth who have been here today to help us get through this. Awesome students, awesome leadership. We really appreciate them so much. And thank you for all of you who have donated to us in the past. Keep doing that, and we'll have more of these. Thanks for coming.